let's jump into it with one of my favorite new segments, which is That Would Never Work in Therapy, which is
Oh,
where
I do
we
like this one.
take a pop culture classic where a patient, in this case, becomes consumed with a therapist's life, has constant contact, zero boundaries. The
Oh, oh,
therapist is
oh,
getting pulled into
oh, wait,
personal
wait, can
relationships. What do you got,
I?
Gail?
Gail's gone.
I
For
don't know
those
what
of you not
happened to her.
watching
She
on video,
disappeared.
Gail's disappeared.
I got my goldfish.
Yes, there features a goldfish. Dan is still piecing it together.
I
But in this case,
Goldfish name is Bob.
Oh, I
Oh.
have, it's funny because patients, clients of mine have often mentioned the movie What About Bob
Hmm.
and asked me my thoughts or opinions on it. And I have thus far in my life made it the age of 61 and successfully avoided seeing the movie. And I say successfully avoided because it is intentional. What's
well,
that?
so
I
let me.
understand that. I understand it's Bill Murray and he is a national treasure.
Yes, he's
And
amazing. He's
and at and at the same time, I have made the affirmative decision, and I do this with a lot of films and TV shows with psychologists in them. I make the affirmative decision not see them because I hate the way we're portrayed. And at the same time, I know it's great, and I know Bill Murray is a national treasure, and I admit freely that this is a flaw in my personality structure. It
I
is both
wouldn't say it's a
egosyntonic and
flaw. I
ego
think you
dystonic.
demonstrate very good boundaries and good clarity about self, right? And in my
Okay.
defense, Richard Dreyfuss is a psychiatrist. I do feel like psychiatry has like a different level of understanding of our boundaries, but
Maybe,
neither here nor
maybe, and
there.
people always mix up psychiatry and psychology, and that's annoying. And
Family can't
I have
figure
just,
that
I have
stuff
successfully avoided seeing the film. I'm
Well,
61. I got to make it hopefully another. I'm really hoping that I can avoid the movie for another 30 years and then maybe watch it when I'm 91 in like in hospice or something. Um, but so far I've successfully avoided it, and I plan to
out.
continue to
All
for
right.
the
Well, my
foreseeable.
my 80-year-old self will be there to push play on the VCR for you.
Fair enough.
okay, let me give you additional context to
Oh,
refresh
Okay.
your memory,
context.
and the
Well,
reason.
refresh. There's nothing to refresh here. He
Well, no,
has
no,
no
no.
memory, and this is
I
not a
know,
comment on his self-proclaimed dementia. This is because he's never seen the movie.
I know. So
Yeah. What am I going to know?
I'm going to shape it for him, and you'll help him along. But really, the reason that
Wait, wait,
this
wait, wait,
was
wait, wait. You're going to oversell my ability to remember this movie. While I have seen it, when did it come out, Michael?
I want to say like
I'm going to
86
guess
or 87.
1996, but I don't know.
No,
Yeah,
it's
I,
definitely
I
earlier than that.
maybe I think I saw it on VHS and maybe the late 80s, early 90s. So it's been a minute.
Yeah, it came out in 1991.
Okay.
Um,
Oh, okay.
All right.
so
All right.
okay, so the reason that I wanted to choose this one is, I mean, you watched the movie. I remember watching the movie probably when it first came out or
I don't.
thereabouts, and it seems ridiculous. However, with the growth of concierge medical care and psychological care, I think it is an
Interesting.
interesting conversation. So that's kind of the
Hmm.
lens. But let me give you.
Wow.
I'll paint a little picture for you,
Okay. Paint
which
away.
is Bob, an intensely anxious client, starts escalating his contact with Dr. Marvin beyond anything appropriate. He calls repeatedly, shows up uninvited, and eventually inserts himself into Marvin's personal life, including vacations and family time. The bit is that Marvin keeps getting pulled in, losing professional distance and reacting emotionally, while Bob treats the therapist like a caretaker and an attachment figure rather than a clinician.
I
So
know more about it than I need to already.
so I'm curious, like, especially in the wake of all the concierge medical care options, what are those
Well,
clinical boundaries like? What's being violated? Why do
I
we
mean,
need those
so yeah,
boundaries? And unpack it.
and Gail and I provide some level of concierge care, and which means that if someone is having an issue in between visits, we do respond to outreach via messaging. We might set up a phone call. We might set up a Zoom call, although we don't use Zoom, but everyone calls it that.
It's like
It's like
Kleenex.
Kleenex, exactly. It's like Kleenex. We might set up a Zoom call. However, at all times, it's the question is, what's serving the client's needs at that moment, and within the clinical appropriateness of that call. So you don't want to foster dependency, and at the same time, you want to be present for the person in a way that's a higher level of care than, hey, we'll talk about this at your session next week. And it's up to the therapist to maintain those boundaries. And without seeing the movie, like clearly Dreyfus doesn't doesn't maintain his therapeutic boundaries.
Yeah, I mean, I would agree. My memory of the movie is he gets drawn in a bit more personally because he is annoyed, right? And so then we would have some countertransference happening where he's losing some of his
Oh,
objectivity.
define that.
Oh, thank you. Countertransference, which is the feelings that sometimes therapists hold about what's going on in the room or about a particular client. So transference being the feelings they have about us, countertransference being the feelings we have about them. And that happens, and that's a normal thing. But in our training, we are taught to be aware of that, to talk about it, to process it, and if it in some way clouds our ability to be clinically appropriate and present for the client or the patient, then we need to take steps to remedy that. And that might include distancing ourselves from the case and helping make a referral to a clinician that can better manage that. So in this case, I think the countertransference and his annoyance starts to show, and he is trying to convince everyone around him of this narrative and is feeling overshadowed because Bob is in some ways more likable, and the more Dreyfus is giving in to his countertransference, the more likable Bob seems, so people want to keep him around. Like, this gets really, kind of muddy in the movie.
Right.
Our job is to manage that and to say, hey, this amount of contact is really a clinical issue. Let's talk about the clinical issue here and keep it at a clinical level, make it an opportunity for an intervention, as opposed to just trying to push him away, which is activating this particular character more, right?
Right.
It actually increases the reassurance seeking instead of helping to manage it in a clinical way. So I think this is problematic, and I like the lens that you're asking about it in terms of the concierge medicine, because concierge medicine and psychological care sort of pulls for this idea that you have unfettered access to your clinician, but you don't.
Wait. No, go ahead. Sorry. I'll let you finish.
Not in that totally available kind of way. While we are responsive, we're really responsible to think about what is the most clinically appropriate intervention for this individual. So let's say you're between sessions and someone says, hey, I'm having a real total shit day. I really, I need to talk something through with you. Fine. Concierge medicine would say, sounds like you need something in between. And we would decide clinically how much contact is appropriate. Is this a 10-minute little chat through? Is this a full extra session that we're going to find time in our schedule for? Right. But it is not then to serve our own ego or needs, or, we got to be careful not to be swooping in and caretaking or snowplowing for this person, right? So there's some decision making that's happening as we provide that care in the concierge model.
And this comes up even in non-concierge medicine with psychology. People will ask, like, how frequently do you see your clients, or how long are your therapy sessions? And the therapist is like, well, I won't see a therapist. I'll see my clients. I see all my clients once a week. And I'm like, no, because that's not necessarily everyone's need, and we should be seeing people at a frequency that is driven by clinical need and by and what's, rather than by some predetermined frequency. In the same way, if the person calls and is engaged in kind of concierge level of treatment, we would do what is clinically appropriate. However, if the person needed to talk to me every single day, they probably need a higher level of care. They probably need an intensive outpatient program or a partial hospitalization program, something like that, if they need to have that daily contact in order to stay safe and healthy. However, if they needed to process things a few times a week, or then have a brief touch base in order to work through stuff, absolutely, that might be part of concierge medicine.
For a defined period of time, right? Again, if this is something that is chronically going on for months and months, we might be asking ourselves, what is the appropriate level of care? I think where concierge medicine in particular gets maybe muddled or unclear is this idea that you have this access to your clinician, and so you get to use it. And concierge medicine still needs to be driven by the clinical decision making that we make no matter what sort of system we're in, you wouldn't blanket see everyone once a week because that's not clinically appropriate for everyone. So you're still making clinically appropriate decisions. What's different is the availability to touch base, send messages, work through whether or not a meeting or a treatment, sooner than originally scheduled is still clinically appropriate. You have a bit more access, direct access, as opposed to if I call in my corporate health system to, let's say, my kid's doctor, and I need to call, I end up talking to a nurse who does not take the message as I've given it. So then the nurse calls me back and misses me, despite my saying I'm not available at this time. They call me at the time I'm not available. This did happen, by the way. And then
I was going to say, this sounds
right,
like an act that you are grinding.
A little bit, right? So then I get on the phone and say, hey, look, I'm still trying to get a hold of this doctor. Will you tell me what this is about? I have told you what this is about. I do need to talk this through with my child's doctor. He saw him yesterday. Right. And then you're able to get through the red tape. And I'm saying this as a person who, has worked in this healthcare system and knows the players involved. And it's still really hard to talk to my clinician, especially in the cases of, care for minors, because they disrupt the access for medical messaging, which is a sort of a close parallel or close-ish parallel in corporate healthcare to being able to have that access, but you still have a person in between. So in concierge medicine, we really reduce that friction and that administrative layer so that the individuals have clear access to us and we can make very quick clinical decisions. And I think in concierge medicine, we also tend to keep our panels smaller. We know our folks, very deeply and can kind of anticipate what might be going on. So, and that way, I think concierge medicine it's important to distinguish it. I actually think, Michael, one of the things that we didn't talk about and haven't talked about in this episode is really not concierge medicine and the difficulty holding the boundaries, although certainly it's a risk. It's actually, I think, working in these smaller geographic areas, and especially when you see a clientele that lives in the same area. Now let's talk about family enmeshment and, people popping up in unexpected places. We've dealt with this for a long time, right? And both you and I, Dan, have worked in small areas where, maybe we are the psychologist that is providing services, or you serve a particular role, and then you end up at the Best Buy, or you need a sign painted, or whatever it is. And your client is the person who's here in front of you. And now that becomes, I think, sometimes a trickier boundary to negotiate, because you know something clinically about this person, but you're out in the world and we have laws that protect your identity. And quite frankly, we want to have our own lives too. We don't want this bleeding over. And so making sure that we're balancing that in that local way, I think, is often harder for clinicians, or maybe for me, I'll speak for myself, than concierge care.
Right. Agreed. I have nothing more to add to that.
Okay.
Well stated.
Fair. Yeah, so I like that, thinking about the small community piece of it. I hadn't considered that. You're right, that you run into people and you might have those, you might be asked on the spot about something that you weren't prepared because you're in your personal life then. So I guess really what I'm hearing is that, the problem with What About Bob is his need is not the problem. It's the lack of firm boundaries and not defining those well. That Bob sees the boundaries as blurry. His psychiatrist, in this case, seems to struggle with them as well and doesn't provide that kind of structure for Bob to
Well,
kind of
I mean,
operate in.
my memory is he tries to, but he does it in a way that is personal, right?
Yeah.
He is annoyed and
Yeah.
he is rejecting, which is increasing symptomology, not helping Bob, in this case, manage
And
symptomology.
we can't do that. I mean, a big part of the task. Yes. Is a therapist ever annoyed, frustrated, happy?
Yeah.
Like, do we have feelings of, gosh, this is someone I'd really love have a beer with sometime? Do we get like, oh wow, this person is frustrating to me? Yeah, of course we're gonna have feelings about people we talk with, or and it's our task to continue to treat them in the most appropriate way with the proper amount of distance. And if we can't do that, as Gail, as you mentioned earlier, if I can't do that, it's my job to refer that person to someone who can, because I can't let my own shit interfere with. And therapists do this all the time. after losing a partner or a divorce or a particularly difficult time with a child, they may choose to not work with people who have similar issues for a period of time because they don't believe they can maintain that distance, which is really critical. Therapy should never be around about me and my stuff. It's got to be about my clients' issues.
Awesome.
Well said.
Well,
Now, can I correct the record? I just set the record straight. My little Bob here, my fish. I did not create him in with the idea of representing the movie. It was a total accident, but I had done this craft, and I usually do one for myself before I give it to someone else. And I thought it was funny to give my kids' classroom teachers a fish that the kids couldn't kill over the summer. So I thought this was kind of funny. And then I had made one for myself, put it in my office, and someone referenced the movie. And I thought, that's funny. I need to name my fish Bob. So it was a hilarious after effect.
Wonderful.
yeah. Well, thanks for joining us on That Would Never Work in Therapy, or maybe it would. I don't know. Next time, we'll check out another moment in pop culture and see what they do with it.